Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. Today, our focus delves deep into the realm of thrombotic disorders and laboratory. Our exploration spans various crucial topics, including predictors of arterial thrombosis such as C-reactive protein, plasma homocysteine, fibrinogen activity, and lipoprotein A. We'll also delve into disseminated intravascular coagulation, addressing its causes, pathophysiology, symptoms, laboratory diagnosis, specialized laboratory tests, and treatment. Furthermore, we'll unravel the complexities of heparin-induced thrombocytopenia, exploring its causes, clinical significance, platelet count, and laboratory tests for HIT treatment. If you're ready to delve into the mysteries of thrombosis, hit that like button, subscribe, and let's start. Arterial thrombosis predictors, decoding the clues that our arteries hold. Stick around for some groundbreaking insights. Arterial thrombosis, the stealthy culprit behind conditions like heart attacks and strokes. Let's uncover the predictors that often play hide and seek with our traditional understanding. Traditionally, we've relied on elevated levels of total cholesterol, TC, and low-density lipoprotein cholesterol, LDLC, to predict arterial thrombosis risk. Or, we'd keep an eye on the total cholesterol to high-density lipoprotein cholesterol ratio, TC, HDLC, especially if HDLC was taking a nap. But here's the plot twist: a third of primary cardiovascular events happen in folks with normal lipid profiles. And get this, half of those with proven lipid risk factors never experience arterial thrombotic events. Cue ongoing research, where scientists are turning over new stones. They're exploring lipoprotein subtypes, components of the fibrinolytic pathway, and markers of inflammation. It's a quest to find additional predictors of arterial thrombosis risk. Enter potential markers like homocysteine and high-sensitivity C-reactive protein, CRP. These aren't just random names, they're the characters in our story, adding layers to our understanding of arterial thrombotic events. Let's spotlight one of these characters, C-reactive protein or CRP. A true detective in our blood, let's get to know this fascinating protein. CRP, a calcium-dependent pentameric ligand-binding member of the pentraxin family. It's a liver-produced superhero that circulates in plasma at concentrations below 0.55 mg per liter. Discovered in 1930, CRP is an acute-phase reactant. Picture this: it exhibits a 1,000-fold increase in plasma concentration within hours after the onset of inflammatory events like infections, trauma, or surgery. It's our body's rapid response team. Now, labs use manual semi-quantitative assays to detect extremely high CRP levels. It's like our protein detective putting on a magnifying glass to confirm inflammation and monitor the effectiveness of anti-inflammatory therapy. But wait, the plot thickens. In the late 90s, we got a new tool, high-sensitivity CRP or hsCRP. This assay documents modest but chronic CRP elevation, using sensitive monoclonal antibodies. hsCRP levels at or above 1.5 mg per liter signal low-grade inflammation, correlating with an increased risk of heart attacks and strokes. It's an independent measure, a soloist distinct from the lipid profile, predicting cardiovascular or cerebrovascular disease. And here's where it gets interesting. Combine hsCRP with total cholesterol and TC, HDLC ratio, and you've got a holistic approach to assess the risk of a heart attack. It's like combining puzzle pieces for a clearer picture. Laboratory professionals also use hsCRP to keep tabs on the anti-inflammatory effects of statins, our allies in the fight against inflammation. Next, we're on a journey through the fascinating world of homocysteine. This sulfur-containing amino acid might be small, but its role in arterial health is massive. Let's unravel the secrets together. Let's start at the beginning. Homocysteine is like the VIP guest in the metabolism of dietary methionine. But how does it become the center of attention in our health story? Imagine this: homocysteine concentration in your plasma is like a delicate dance. It depends on a balanced diet with enough protein and the right levels of vitamin B6, B12, and folate. And who are the choreographers of this dance? Three enzymes: cystathionine B synthase, 5,10-methylene tetrahydrofolate reductase, MTHFR, and methionine synthase. These enzymes are like the superheroes regulating homocysteine. Vitamin B6, folic acid, and vitamin B12 are their trusty sidekicks. But watch out! Deficiencies in folate, B6, or B12, common MTHFR gene quirks, or inherited deficiencies in the enzymes can throw off this dance, leading to increased plasma homocysteine, a condition known as homocysteinemia. Homocysteinemia, especially during fasting states, is a red flag for arterial thrombosis. The relative risk ratios speak volumes: 1.7 for coronary artery disease, 2.5 for cerebrovascular disease, and a whopping 6.8 for peripheral artery disease. It's like homocysteine is trying to tell us something crucial about our arteries. Now, some people have a special genetic code, homozygosity, for the MTHFR C677T mutation. It's associated with homocysteemia, but interestingly, it's not considered an independent thrombosis risk factor. The plot thickens. The link between homocysteemia and coronary artery disease involves intriguing theories about potential damage to endothelial cells. While we don't have conclusive evidence yet, it's clear that maintaining optimal homocysteine levels is essential for our overall health. Fibrinogen, the unsung hero in blood clotting. This vital protein is measured using advanced lab techniques like immunoassay, nephelometry, or the clot-based method. But why does it matter? Fibrinogen is like the conductor in the orchestra of clotting. It plays a crucial role in forming blood clots. But here's the twist: chronic high fibrinogen levels are linked to the risk of myocardial infarction, even in seemingly healthy individuals. The risk triples as we move from the first to the fifth quintiles of fibrinogen concentration. And here's a plot twist: fibrinogen levels are best buddies with total cholesterol. They show a direct correlation, making them a dynamic duo in predicting hypercholesterolemia and identifying patients at a high risk of new coronary events. But fear not. Low normal fibrinogen levels are associated with a lower risk of cardiovascular events, even if you have high total cholesterol. Embracing a heart-healthy lifestyle, including statin therapy, smoking cessation, and exercise, can work wonders. These choices not only lower fibrinogen levels but also align with your overall risk profile. Now, let's shift our spotlight to lipoprotein A, a form of low-density lipoprotein, LDL, that's making waves as a predictor of arterial thrombosis. Lipoprotein A levels are measured through the fascinating world of enzyme immunoassay. Now, here's an interesting tidbit: lipoprotein A concentrations are higher in African Americans compared to European Americans. But here's the catch: it's a more robust predictor of thrombosis in Caucasians. How does lipoprotein A contribute to the thrombotic tail? Picture this: it has an antifibrinolytic property. It competes with plasminogen, the clot-busting hero, for binding sites on newly formed fibrin polymer. This reduces the available plasmin activity for clot degradation. And that's not all: lipoprotein A also plays a role in the overall concentration of LDL-C. The plot thickens as we uncover the interconnected web of lipid dynamics. But don't worry, just like fibrinogen, statin therapy can effectively lower lipoprotein A levels, mirroring its impact on LDL-C. It's like having a superhero duo fighting against arterial threats. Disseminated intravascular coagulation, also known as DIC, is like a storm within our blood vessels. It's a widespread activation of the body's blood clotting mechanisms triggered by a systemic disease. Imagine it as a cascade of events affecting various aspects of hemostasis. DIC doesn't play favorites, it affects the vascular intima, platelets, leukocytes, coagulation factors, coagulation control pathways, and fibrinolysis. Small blood vessels get partially blocked by fibrin microthrombi, leading to a consumption crisis of platelets, coagulation factors, and fibrinolytic enzymes. As these tiny fibrin microthrombi form, they interfere with normal fibrin formation, triggering toxic and inflammatory processes. Elevated levels of fibrin/fibrinogen degradation products, including the infamous D-dimer, become the telltale signs of DIC in the laboratory. DIC can be acute and uncompensated, resulting in deficiencies of multiple hemostasis components. On the flip side, there's chronic DIC, where the body tries to compensate by producing more clotting factors and platelets to counter the increased consumption. Don't underestimate DIC. Despite being a thrombotic process, the formed thrombi are small and ineffective. This often leads to systemic hemorrhage as the first or most noticeable sign. Acute DIC is a medical emergency, and timely intervention is crucial. Now, let's uncover the diverse range of factors that can set the stage for DIC. It's not just one villain. Any disorder contributing hemostatic molecules or promoting their secretion may cause this condition. Here's a key insight: the acuteness of the patient's illness directly correlates with the severity of DIC symptoms. The faster it hits, the harder it strikes. Chronic DIC has its own set of instigators, including vascular tumors, tissue necrosis, liver or renal diseases, chronic inflammation, use of prosthetic devices, and adenocarcinoma. Malignancies like pancreatic, prostatic, ovarian, and lung cancers, among others, are often linked to DIC. Now, for the acute triggers: obstetric emergencies, intravascular hemolysis, septicemia, viremia, burns, acute inflammation, crush injuries, dissecting aortic aneurysms, and cardiac disorders can set the stage for acute DIC. If you've ever wondered how our body's clotting mechanisms can go haywire, you're in the right place. Let's get started. First things first, coagulation can kick in at any moment due to specific triggers. But when DIC is initiated, it follows a fascinating yet predictable sequence of events. Our main character in this story is circulating thrombin. This little player activates platelets, coagulation proteins, creating positive feedback loops, and catalyzes fibrin formation. Essentially, it sets off a cascade of clotting events, consuming control proteins along the way. But that's not all. The fibrinolytic system, responsible for breaking down clots, joins the party. It can activate at the level of plasminogen or tissue plasminogen activator, TPA, after fibrin formation. Damaged endothelial cells release coagulation-active substances, adding more complexity to the process. And here come the monocytes. Responding to inflammatory cytokines, they secrete tissue factor, contributing even more to the drama. This intricate dance of factors sets the stage for what happens next. In DIC, some fibrin monomers don't play by the rules. They circulate as soluble fibrin monomers, coating platelets and coagulation proteins, exerting an anticoagulant effect. It's like a plot twist in our clotting story. As the plot thickens, platelets get caught in the web of fibrin or get exposed to thrombin, triggering platelet activation. This not only exacerbates coagulation but also causes thrombocytopenia, a reduction in platelet count. Meanwhile, control in the coagulation pathway is slipping away. Proteins like C, S, and antithrombin are consumed, leaving our once well-regulated system in disarray. The combination of thrombin activation, circulating plasmin, loss of control, and thrombocytopenia all contribute to the overall hemorrhagic outcome of DIC. It's like a grand finale, but not the kind we'd hoped for. But wait, there's more. Free plasmin doesn't stop at digesting fibrinogen and fibrin. It triggers the complement system, leading to hemolysis, and activates the kinin system, causing inflammation, hypotension, and shock. It's like a domino effect affecting multiple systems. DIC can be triggered by various conditions like fibrinolytic therapy, amyloidosis, or liver disease. In these cases, plasminogen activation occurs independently of the coagulation pathway, resulting in measurable changes in lab tests. DIC symptoms often play hide and seek, overshadowed by the underlying disorder. Whether chronic, acute, or fulminant, microvascular thrombosis in major organs can wreak havoc. Think impaired renal function, adult respiratory distress syndrome, and central nervous system manifestations. Skin, bone, and bone marrow may also take a hit, with conditions like meningococcemia, chickenpox, and spirochete infections presenting as purpura fulminans. Now, let's talk about how we diagnose DIC. It's not just a guessing game, we need some hard evidence from the lab. The initial lab profile includes a bunch of superheroes: platelet count, blood film examination, PT, PTT, D-dimer, and fibrinogen assay. If PT and PTT are playing the slow game, it's a sign that coagulation factors are getting consumed. But here's the twist: fibrinogen concentrations can rise due to inflammation, adding a bit of suspense to the plot. A peripheral blood film is like our detective magnifying glass. It confirms thrombocytopenia in almost all cases, and the presence of schistocytes. That's a clue leading us straight to a DIC diagnosis. Now, let's talk about the MVP of this game, D-dimer. Elevated D-dimer levels are crucial for diagnosis, often reaching heights of 10,000 to 20,000 nanograms per milliliter in DIC cases. But beware, it's a versatile player. Elevated levels can also pop up in inflammation, sickle cell crisis, pregnancy, and renal disease. Here's a pro tip: judiciously using the D-dimer assay can be a game changer. It helps us rule out DIC and localized venous thromboembolic disease without resorting to invasive tests like pulmonary angiography when suspecting pulmonary embolism. When it comes to DIC diagnosis, we don't just stop at the basics. We bring in the heavy artillery, the specialized laboratory tests. Meet the superheroes of DIC diagnosis: protein C, protein S, and antithrombin. These assays are not just consumed in DIC, they're our allies in establishing therapy necessity and monitoring its effectiveness. Factor assays decode the PT and PTT results, while thrombin time and reptilase time play sensitive roles as DIC screens. It's like revealing the hidden layers of a mystery. Ever wondered about the fibrinolytic pathway? Tests like serum fibrin degradation products, chromogenic plasminogen activity, and TPA and PAI-1 immunoassays might have the answers. These tests are like our secret agents, revealing the nuances of primary fibrinolysis. Now, let's talk about the treatment strategies for DIC. It's not just about stopping the clot, it's about understanding and addressing the underlying disorder. The primary focus is on the underlying disorder. Whether it's surgery, anti-inflammatory agents, antibiotics, or obstetric procedures, we aim to normalize hemostasis, especially in chronic DIC. Supportive therapy is the backbone. Maintaining fluid and electrolyte balance alongside medical and surgical management keeps things in check. In acute DIC, where multi-organ failure threatens, we have two categories of treatment: slowing the clotting process and replacing missing warriors, like platelets and coagulation factors. Enter unfractionated heparin. It's like the pause button for uncontrolled coagulation activation. But, of course, we keep a keen eye out for potential bleeding risks. Thawed frozen plasma steps in, replacing lost coagulation factors and blood volume during acute DIC hemorrhage. And if transfusion-associated circulatory overload is a concern, we have substitutes like prothrombin complex concentrate, fibrinogen concentrate, and factor VIII concentrate. For severe thrombocytopenia, platelet transfusions are our heroes, closely monitored through platelet counts. Monitoring thrombotic events has reached a whole new level. Beyond D-dimer, we have peptides and coagulation factor complexes like thrombin antithrombin, TAT, and prothrombin fragment F112, PF112. These are like the secret agents of thrombosis detection. TAT and PF112 immunoassays offer us a closer look at localized venous or arterial thromboses. Sensitive and specific, these tests are invaluable in conditions like DIC, septicemia, and more. But how do they work? PF112, released during prothrombin conversion, has a plasma half-life of 90 minutes. Elevated PF112 may signal venous thromboembolism. Stay tuned for why its concentration is reduced by heparin or oral anticoagulant therapy. Now, TAT, the covalent complex formed during antithrombin neutralizing thrombin. Enhanced by heparin, TAT has a short half-life of 3 minutes. We collect plasma specimens with precision to prevent in vitro release or activation until assay time. Moving on to a critical topic, heparin-induced thrombocytopenia or HIT. It's like the dark side of heparin treatment. 1% to 5% of patients on unfractionated heparin, UFH, develop IgG antibodies against heparin platelet factor IV complexes. In 30% to 50% of cases, immune complexes bind platelet Fc receptors, triggering platelet activation and the infamous thrombocytopenia. HIT can be a medical emergency, with a mortality rate of 20%. While venous thrombosis is more common, arterial thrombosis can lead to severe complications, from pulmonary emboli to limb gangrene. Even low molecular weight heparin, LMWH, is not exempt. How do we catch HIT in action? By monitoring platelet counts every other day during heparin administration. A decrease suggests HIT. But the interpretation can be tricky. Enter the 4TS, a strategic approach considering factors related to thrombocytopenia, timing, thrombosis, and other clinical settings. It's our guide in HIT diagnosis. Did you know that at least 10% of hospitalized patients receive heparin? That's a significant number, making it crucial for acute care labs to have a reliable procedure to confirm HIT. Let's explore the fascinating world of lab tests for HIT. Most labs offer a heparin-induced antibody immunoassay. While sensitive, it's not always conducted urgently. This test can give early positive results, sometimes even before clinical signs of HIT appear. But beware, false negatives can occur due to various factors. It's a delicate dance between sensitivity and potential pitfalls. Some labs take it up a notch with aggregometry or lumiaggregometry methods to confirm hit. Aggregometry, although technically demanding, has its merits. Washed platelet suspension lumiaggregometry, even more demanding, could potentially be more sensitive. But wait, there's more, the washed platelet serotonin release assay, the reference method available in reference labs. It's the gold standard. Now that we've cracked the lab code, let's talk treatment strategies. Upon hit detection, immediate discontinuation of UFH or LMWH is non-negotiable. But what's the next move? Stopping anticoagulant therapy altogether is risky. So, alternative anticoagulants step in. LMWH, as a sole anticoagulant, is surprisingly safer, causing hit in only 1% of cases. But watch out, it's a no-go as a UFH substitute due to its antibody reactivity. Coumadin. Not recommended due to its slow onset. Enter the stars of the show, Fondaparinux, a synthetic pentasaccharide mimicking heparin's magic, and direct thrombin inhibitors like recombinant bivalirudin, Angiomax, and argatrobin. These alternatives are administered as continuous infusions, and monitoring them is a whole other adventure with options like PTT, ACT, heparin clotting time, or plasma-diluted thrombin time. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.